friends and colleagues. Yes, we have an extraordinary panel now. We're seeing history in the making. And I was just commenting before that I have to put my glasses on in order to read Adam's titles to you because he has more than one. Adam Boehler is CMS Deputy Administrator for Innovation and Quality. That should be enough on its own. Director of the Center for Medicare and Medicaid Innovation and Senior Advisor for Value-Based Transformation and Innovation at HHS.
Molly, the rule in Washington is the simplicity of the title dictates how much power you have. Powerless.
Right, yes. They just keep passing you around, right. And Dr. Mandy Cohen is Secretary of the North Carolina Department of Health and Human Services. And we are...
One title, more power.
Yeah. There we go.
Drunk on power. So this afternoon, our question is, a lot of the discussions that we've had and that go on about improving health and health transformation begin with coverage. But there's a heavy emphasis, more and more, and certainly one that US of Care is emphasizing very heavily, on how we're actually transforming the care itself, access to care and the quality of care and the nature of care and its cost effectiveness as well. And so that's the focus now with this panel. And so what we want to do is give people who haven't had a chance to hear from you individually to talk first about what your ambitions and your aims are for the work you're doing with your agency, to understand the CMI approach to this and what you're working on and accomplishing in North Carolina. And then secondarily, we'll move to the collaboration between federal and state as our emphasis. But if we could start first, maybe Mandy with you, about what your goals were as you came in and what you've accomplished to date and what you're excited about as you see in the future.
Great. Well, thanks, Molly, and good afternoon. It's great to be back in DC. I see a lot of friends and colleagues and mentors who are here in this room. So let me give you a thumbnail on North Carolina before I launch in so everyone knows a little bit more about our state. 9th largest state in the union, fastest growing, 10 million people, very purple. We have a Democratic governor, who's obviously my boss, Roy Cooper, and a GOP supermajority in our state legislature, which is going to just change to just GOP majority starting next year. That means no Medicaid expansion, and also a decision by the General Assembly before I joined the North Carolina team to move the Medicaid program to managed care for the first time. We're the largest state that has not moved our Medicaid program to managed care. Hard hit by the opioid crisis, classic issues, urban-rural divide, racial ethnic disparities, really what I think is a model of what the country looks like. And that's why I find it really inspiring and challenging to be there and do this work. And my agency, when it says Health and Human Services, is actually referred to as a mega agency, meaning that in our department, we have not just Medicaid, but public health, mental health, including a number of psychiatric hospitals that we run. And then I also have the levers of the SNAP program, the TANF program, early childhood education, and vocational rehab and education. So as you think about the social determinants, or what I call healthy opportunities, I actually have a lot of those levers in my department. So what I wanted to focus on, I think, is how we are using our biggest lever, Medicaid, to do some of the driving towards that improvement that you were alluding to. And so as we make this change to managed care, we've really tried to embed 3 things in that transition in a very purple state, in a way that I think will demonstrate not just the state-federal partnership, but also the bipartisan partnership here. And so one has been, first, a focus on integrating physical and mental health, as well as an investment in primary care. So right now, the way we pay for physical and mental health is in many Medicaid programs is very siloed, and thus we get a lot of siloed care. We're bringing that together as we move to managed care, as well as making a pretty hefty investment in primary care and local care coordination. Second lever is really around value, and not just moving to a capitated environment, but making sure we move that capitated environment to one that includes alternative payment models. So we have some pretty aggressive goals for our soon-to-be managed care plans to move to alternative payment models very rapidly. And then the third is what we've gotten a little more national recognition for lately, is our focus on the social determinants, or again, what I'm calling healthy opportunities. Social determinants, for me, determinant feels like you can't move it. Opportunities feel like you can actually make some change. So we call it healthy opportunities, and I bet we'll spend some time talking about it, but this is where we are embedding in many parts of the Medicaid program and beyond how we are thinking about food, housing, transportation, violence, and employment for folks and their ultimate health. And this all falls under the rubric that I've been talking about for a couple of years now as buying health, right? I have a $20 billion a year budget. It's not as big as some budgets. But I want to make sure I'm using every one of those dollars in the service of health. So when you ask me what my aim is, it's health. But that means we have to reorient very differently. It means we have to spend money on different things. It means we have to measure things differently. And that's what we're trying to do with sort of all of these pieces. It's in service of buying health. And I'm sort of excited about the places in which we've had the federal government and the state of North Carolina have partnered together on a pilot in the healthy opportunities space, a big one, $650 million pilot that I'd be happy to dig into, but all in the service of buying health.
Great, and we'll come back to that because that is obviously one of the things to ask about. So Adam, it's worth, I think my sound system's giving a little feedback. What I wanted to ask also is if you would comment a little bit about your move very abruptly from the private sector to the public sector. I've worked in almost every part of the healthcare industry, and my job as health commissioner in New Jersey, a government job, was still the best job I ever had. And second best was running the California Department of Health Services, where we covered double the people for $18 billion, so prices have gone up. But it'd be interesting to hear it from that point of view, too.
Sure. So I'll give a little bit of my background to start, because it kind of pushes into that question, Molly. So before I joined here, I started a business called Landmark Health. And what Landmark is they're the largest provider of medical house calls in the country. So the business provides 24/7 in-home medical care, as well as social workers, pharmacists, dietitians, psych NPs, addictionologists. And so the business model is we would go out and take full risk for very complex chronic patients, and that would be Medicare, Medicaid, and duals, and then lower their costs by treating them 24/7 in the home. And one of the largest capitated groups in the country. So some of my familiarity in the space is from that, and what I was doing before I took the job in April was started and running that company, now about 1,000 employees, about $2.5 billion of risk, treating folks, and it was a fully employed model. So we employed all MDs, NPs, nurses, and then the behavioral staff and social workers as well. And our experience was that when you do treat the whole person and when you look holistically, you do make a big difference. And I think, one of the areas here, I think a lot in my role now about payment models. I'm very oriented toward payment models because I think what you put in from a payment model perspective generally dictates the outcome. And when you pay people for doing the right thing, and what I would define the right thing is doing the right thing for American patients, so lowering cost, improving quality, driving choice. When you make it so that people make money for doing that, then they do that. It's sort of a human behavior thing. And so let me use a specific Landmark example. When we would have a 94-year-old patient that had 10 chronic comorbidities, maybe they were on 15 or 20 unique prescriptions, and they would call at 2 a.m. And have flu-like symptoms, the typical approach would be to send that individual to the hospital. And my grandmother, she died when she was 100. Part of the impetus of starting the business was I saw that. She was in and out of the hospital all the time. My dad is a doc too, but he couldn't manage her by phone in these areas. And she would go in and she'd come out worse off than she was. and you were thinking, what's wrong with the system? The hospitals didn't like it. That's not where they're making money. They're making money on procedure volume. Those are the patients readmitting. Nobody was doing well, and the healthcare system itself was suffering. But more important, my grandmother was suffering, and it was hastening kind of her demise. And so we thought, how could we do this different? Now, the difference in the Landmark case was when we had full risk and we had full kind of accountability for that patient that I gave you an example, instead of getting paid $150 for a visit, which, by the way, you cannot send a doctor to somebody's home at 2 a.m. on a Sunday for $150 without taking a massive loss. My cost was $700-800 to do something like that. You're talking on-call Sunday. But that patient would then be admitted to the hospital. They'd go in, usually ED. Admit rate of a complex chronic patient like that, I don't care if they had a hangnail. They're going to get admitted in the hospital. There's going to be a lot of tests. They're going to be discharged probably to a nursing home, maybe readmitted, and then start a significant decline from there. That's $50,000 of expense. Now you're comparing $800 to $50,000, and that's how the business model worked, and we took 20 to 30% of expense out. So that kind of bellies some of my experience in this. You asked, Molly, why I took the role. I was called by my predecessor, Patrick Conway, now in your state, Blue Cross Blue Shield, North Carolina. We were actively trying to take risk on Medicare patients. We only could take risk on managed care. We didn't want to do fee-for-service. Totally changes around your culture. As soon as you start doing it, it's hard to get out. So we wanted to take direct risk from Medicare. So we were working actually with Senators Cassidy and Whitehouse on a bill, and we were working with CMMI on a demo. And so that's how I knew Patrick. And he called me, and I remember I was on a run. I lived in Newport Beach. I was on a run, and when CMS calls you and you're on a run, you pick up because who did I kill patient-wise? So I was very nervous about the call and huffing and puffing. And Patrick basically asked me whether I'd consider this, and in a really nice way, I said no. And I said no, truthfully, for two reasons. One is I had never viewed myself as going into government at all. Private market guy, honestly, pretty negative conception of the government and how slow and bureaucratic, and I would hate it. That would be what I would have told you a minute before that call. And he basically said, hey, why don't you come in and meet the administrator of CMS? I think you'll like her. And worst that happens is you meet the administrator of CMS. Like, that's not bad for business. I'm like, okay. Speaking my terms on that, maybe I will do that. And so I called my private equity backer, Francisco Partners, and I said, hey, I'm going to go in and take this interview, but I'm not going to take the role. And I'll make a story real short. The reason I eventually did it, there's a few reasons. One is I did like, from a CMMI perspective, the ability to get things done without going through Congress on everything. And so for me, the big question was, I look back at myself and I say, hey, you're on this earth for a certain amount of time. If you're going to judge yourself by what is there because you are there, what wouldn't otherwise be there, judge yourself on impact, and you want to be proud of what you do. I thought this is an ability to impact hundreds of millions of people. And so I thought, if that really is like that, I should do that. And so that's eventually where I got around, was the ability to do it. The other thing I think that was really important is the alumni of CMS. A big decision like this, you speak to everybody, I think. I do. Any major decision, I'll at least speak to a few experts in the area. Here I'm leaving a business that I started, that I love, that's very successful, that is making a big impact. And what if I'm leaving and I won't make a big impact where I am? The opportunity cost of that. I'm moving my family. We lived a block from the beach in Newport. It was nice. Weather just like this. The other thing was really important was the alumni. And I'll tell you, Andy, actually, I spoke to him early. Anytime you make a decision like this, you think, well, I'm going to talk to bulls and bears on this. I really want to get a comprehensive view. And Andy I designated as somebody that I respected a lot, but would tell me why not to do it, right? I mean, Andy's on Twitter sometimes. He sometimes makes comments about the administration. We know you love the administration. But I thought, okay, this is, and I wanted that. I wanted to hear why not. And Andy was completely the opposite. Andy said, Adam, you cannot let this opportunity pass you by. I know somebody like you and the impact you can have. And he was a very strong proponent. And I found that from a bipartisan perspective, there was massive support. And so Andy was very influential in that, as were a number of other people that were former administrators, former HHS people, former CMMI directors. Patrick was very influential. And so that's why I took it, is the ability to try to do that. In terms of our agenda, I worked with the secretary very closely. There are 4 component areas we focus on in value-based transformation, the 4 Ps. The first is activating patients as consumers. The second is providers as accountable entities. The third is payment for outcomes. And the fourth is prevention. And I can walk through those briefly, and then we could obviously talk more on the prevention side if you'd like, Molly.
Yeah, I think what we should probably do is let's go to the description of the waiver in North Carolina and how that connects with your 4 program areas. So maybe we should first get a description from you. I don't know what is my feedback here. So Mandy, can you give a quick description of that and more broadly of what it's been like working in the state level with the feds today?
Sure.
And I'm sorry, everybody should know, this is the first time they've actually met.
Met in person.
In person. We spoke.
Yeah.
We speak, so.
Yes.
Yeah.
Meeting in person. Well, it's been, so when I arrived in North Carolina, given that we're a very purple state and...
By the way, did you see it?
Yeah, so you're nice. It was, I wanted to make sure I understood the needs of the state and that we were mapping to the problems of North Carolina, as well as understanding where, I can't do that work without the support of the General Assembly. And so understanding sort of how do we map a solution set to what was going on in North Carolina, but it's very much shaped by my own personal background as a physician, where, I have similar to hearing your family experience, having a patient experience where I was seeing a patient and, after knowing her for 8 weeks, ordering a lot of lab tests, ordering CAT scans of her belly, about to send her to, a next specialist because I'm a primary care doc. I was thinking, well, this is beyond me. She looked ill, and this woman that I was seeing, she was a young woman, and after spending all of that money, my tech, who checked in the patient, and I'm now knowing her for 8 weeks, said, I really think you need to ask your patient if she has enough to eat. And it still stings, and it still is with me, and it shapes a lot of the thinking that I want to tell you about related to the waiver, because I spent a lot of money in the healthcare system, and I didn't make her one bit healthier. And I went into that room and asked her a non-standardized question about what's going on at home, right? Not the kinds of things I'm going to require of my managed care companies going forward. But it was then where you're able to pull the threads of, as a young woman who was a full-time college student, had commercial insurance, so insurance was not her issue. But she had just left an abusive relationship, embarrassed about it, didn't want to call mom because they thought she was going to marry the boyfriend, and she was essentially living out of her car, and all of her money going to tuition, and essentially the shame of everything was keeping her from reaching out to get help. And you have your own personal cognitive dissonance of what's going on in your own body, right? So that whole experience, but once we were able to sort of move past that, I was able to, help her and connect her to the resources that she needed, though I will say my clinic not set up to help someone for those kinds of things. So it was like a total panic when your patient actually says, yeah, doc, I'm running out of food, and I think we need to acknowledge that. But it really speaks to what's in the waiver. So again, back to that integration of physical and mental health, right? So she's experiencing trauma, and I did not recognize that. I was willing to scan her belly before I was willing to talk about trauma, right? And then the second part of our waiver, again, an investment in primary care and getting to care local, is that she needed help to navigate around resources. And so we want to invest there, and there's been a good alignment and collaboration. But then, at the end of the day, what's going to make her well was not another specialist visit, but was other kinds of resources that we needed to build around her in terms of food and transportation and other things. And so that's what we're trying to do. And I think the most notable part of our waiver is this new expenditure authority that we are getting in our Medicaid program. It's like I said, $650 million, and I keep saying that because I'm proud of the magnitude of that investment, because I actually think it can help us learn, and it is a pilot. So it's very much, we built this as an opportunity to learn about what can really move the needle in social determinants, or healthy opportunities. I hope you all start using healthy opportunities. So the first thing I did when we were starting to think about this was hire researchers and evaluators, because I want this to really be something where we can learn real lessons. And the idea is also to use managed care in that infrastructure. So that's the reality. Most Medicaid is now managed care. So let's build on that infrastructure and the way that and what does managed care do? I mean, essentially they build networks, and then they assess patients for care, and then they authorize services. So let's use that. That's great. So we built that pilot into the managed care infrastructure, and then are going to basically pay for food or housing or transportation interventions that have shown that have evidence base that can work. The classic example is asthmatic kids, right? Where asthmatic kids who are pretty severe get a lot of their care, unfortunately. The emergency room. Where's the most expensive place to get their care? The emergency room. It's not coordinated, it's expensive, mom and dad miss work, kids are missing school, right? The worst of all of that. So what was piloted in North Carolina, as in other places around the country, was an intervention around carpet. So they went to the kids' home, ripped up the carpet, put down new carpet, and gave them an air filter. And not surprising to anyone in this room, right, a lot less ED utilization, so a lot less cost. Classic to what Adam was sharing with his grandmother, right? You need to go at 2 a.m. That's what you just need to do. But if I started by saying, hey, I have a great idea, I'm going to spend Medicaid dollars on carpet, they wouldn't let me keep my job. But we have good evidence, and it's a close also time sequence in that asthmatic, right? You get a really quick intervention and quick result, and I know what I'm measuring. But I really think we are still data poor on knowing what is that right intervention for example, high-risk pregnant moms. I care about that a lot in Medicaid, right? I pay for half the births in North Carolina. I pay for 80% of the NICU care in North Carolina. I care very much about how mom's pregnancy outcome is going to go, both from a cost, obviously, and a quality standpoint. And so, but I don't feel like we have the evidence right now to say, okay, when pregnant mom has these kinds of issues, you give her this kind of intervention. And that's what this pilot is hopefully doing. Not just saying, I'm going to throw the kitchen sink at everyone, because we can't buy, I will tell you, both of us sitting here, we do not have the resources to buy everyone a house and everyone a car. That's not going to happen. So we have to come up with what is that lightweight intervention that can actually move the needle towards health. And so that's what we were trying to set up, and I'm pretty excited about it. It means a lot of work still to be done, and I keep, stay tuned for all the details. But it was a great partnership with CMS. Appreciated. Administrator Verma was integrally involved and pushing us to really refine and hone and really know what we were going to test, as well as linking payments to value over time. So I think we have a lot of the infrastructure there to really learn important lessons. And we were able to do that with the 1115 waiver authority. So we actually didn't need to use the CMMI authority. But again, if you want to think about other populations, the Medicare population and duals, our pilot will not get to those populations. I think that's where the Innovation Center in the next sort of turn of the crank is going to be.
So Adam, how does this fit into what you're seeing? You've probably got a number of other pilots out there that you're testing for similar kinds of purposes. How does that fit in with your work?
Yeah, I think Mandy's approach fits in a couple ways. One, I'll give kind of a general philosophy way and then talk a little bit more about the fourth P, prevention. So just philosophy, our view is it's really hard for us to centrally manage risk for the United States. Thinking about, a state like North Carolina, right? You have there's three major cities. Is that what it's Tri-City or whatever? Sure. Right? whatever.
If you're there, it's
Yeah.
5. But
5, okay. Well, here, look, see, I have no idea. Problem. But I think, you look at a state, you have a number of different cities. You have rural, you have suburban areas. North Carolina is completely different from Hawaii, which is different from Alaska, which is different from Ohio, which is different from New York. And so how, at a federal government level, do we manage that and create programs that are supposed to speak to everybody? One system we sometimes compare ourselves to, or we look at as a cool model, is Singapore. And there's some really cool things that Singapore does, by the way. I mean, they're a quarter the spend of GDP that we are. They do a lot in prevention. However, it is a 4 million person population that looks fairly similar relative to our diverse population in the United States. You cannot centrally manage that. And so part of our view here is, let's get risk out of the federal government hands and push it local, whether that's a state, whether that's a managed care entity, whether that's an accountable physician group, to populations where, to groups that understand the local population, that can tailor care to that local population, that we can give kind of flexibility to do what they need to do, but then also hold their feet to the fire from an accountability perspective. So that, I would say, is a general philosophy, which is we've got to get folks that understand patients that accountability to drive it. So that's one. The second thing, and which is why I think this waiver fits so well in, the second thing from a prevention perspective, so CMMI has a lot of different goals. We have a lot of goals at CMS to reduce cost while improving quality. We spend between Medicare and Medicaid close to $1.2 trillion a year. And if we have really good goals, let's say we take out $100 billion a year. It's a lot of money, but then we went to 1.1 trillion. It's not, groundbreaking in the scheme of things. How do we get to 500 billion or something that's really impressive? You prevent disease before it occurs. And that really is a huge focus, and I'd say it's a few things. One, it's looking at a whole person. So exactly what Mandy's talking about in terms of an integrated view. And when I was at Landmark, there were countless times where we would identify and say, here is somebody that doesn't have a home, that's homeless, that is constantly going to the ED, and we were prevented as a capitated physician group sometimes from paying for some of those things. Or I look at like Geisinger's program around a pharmacy with an F, where they're giving free food to diabetic patients and lowering cost, but kind of really walking the line in what is allowed within Medicare. So I think one thing is allowing people to think about somebody on an integrated level, especially if they're accountable for that population. I think Mandy's completely correct. It doesn't mean, and this is from a Landmark perspective, everybody couldn't get 24/7 concierge care, right? That's concierge care. You pay for that if you have a concierge doctor. But really sick folks do need that, and it pays for itself. It more than pays for itself. We weren't a nonprofit. We did very well for doing the right thing. So I think one is looking at and giving people the flexibility to think beyond medical, because so much of those elements impact medical. The second is we want to think about certain public health initiatives that look at prevention. And I'll give a specific example, and that's the application of artificial intelligence in healthcare. So I think it's very nascent. Healthcare as delivered by doctors is much more of an art than a science. And healthcare is a science. It's all just very complicated. And so we're looking at saying, how do we drive an analytic approach to healthcare and make that more pervasive using the scale of CMS? And so I'll give you two examples. One, we saw a very interesting study that UCSF and Google did around quality. What they did is they looked at derived measures of quality, and they used artificial intelligence, and the net result was not only did they come up with much better predictability than our best quality measures today, they were all derived, so there's no burden on clinicians, which fits right into our idea of patients over paperwork that the administrator is pushing. And so we're going to do a challenge. We're going to do $1 million challenge to identify how can we leverage AI to reinvent quality across the country. And our one criteria that is, in addition to it's got to predict quality better, it's got to be derived, it can't be too black box. We've got to be able to understand it so that clinicians can improve on it. We're also working with a number of AI vendors now to think about how can we get people to a base level of proficiency here. Simple things like probability of somebody that is going to admit in the next 30 days, presence of CKD, progression of CKD to end-stage renal disease. Relatively simple things to predict, but again, you're dealing with a ground zero of nothing generally here, so how can we create that?
It's fascinating. Sometimes I'm sure sitting there, you're thinking if you brought in AI and started talking about how you were going to use AI, that might slow down your current efforts to build, even if it could really help you. How do you balance the policy drive to try to bring all of the state along and the tremendous differences in the competencies of different provider groups? And how do you think, Adam, about the question, I apologize again, I'm hearing this, the question of delegated risk? Because in general, most providers out there have no delegated risk. It's at the level of the MCO. But I think from a policy perspective, it's really interesting that historically we have very convoluted ideas about this at the state level and federal. But you're creating an intermediary organization, I think, for the social determinants work. Mm-hmm. Maybe if you could describe that first, and then we'll go to Adam and then open it up for questions, okay?
Well, why don't I speak to your first point, how do you bring the whole state along? And I'm in a state where coverage is very partisan, but working towards health as well as strengthening our Medicaid program and moving towards efficiency is very bipartisan. And so what I've tried to do since being in North Carolina is to focus on those places where we have alignment. And there has been alignment and multiple pieces of state law passed since I have been there in partnership with me and the General Assembly to integrate physical and mental health, to move forward on primary care investments, to move towards value. And I think you're seeing the support from the administrator and from CMS on healthy opportunities work, that bipartisanship there as well. And I think it starts by focusing, again, on the alignment, and I think the earlier panel really touched on having folks understand things from a different lens and a much more personal lens. The same folks who don't want to expand Medicaid in North Carolina have communities that are deeply impacted by the opioid crisis. They know that we need to do better. They have rural hospitals that are closing, and they know we need to do better. But they are truly worried about busting the state budget. They can't take on debt like the federal government. And so they want and are looking for these solutions where we can drive towards value and drive towards efficiency. We share a lot of that. And so those are the places that we've focused on, and that's been able to be good, which means also as we move into this healthy opportunities work that we have to avoid the pitfalls of fee-for-service that we've been in. So as you think about moving forward, and I'm saying monetizing, but paying for things like food and housing and transportation, we have to think about it differently and skip over some of the lessons we should have learned earlier in fee-for-service and really think towards value early. So you'll see in our pilot very much linking things to outcomes and then flowing that down in a shared savings arrangement to some of the actual vendors who are going to provide food and housing. We can't do that right away because there's some learning curve that we will have to do because we've never done this before. But we definitely want to move to bundled payments and risk contracting even in the social determinant space. I do think we need a little more data and evidence before we can really turn that on and turn up that dial. But we've already built it into our model to look at in the sort of the second half of the work.
That's terrific. Adam.
You're talking about delegation, and so what I would say is, to date, there hasn't really been the ability to take delegation from Medicare. Medicare Advantage, you can. And in MA, probably 30, depends on the region, 30 to 50% of patients are in primary care delegation that are either capitation or 50 up, 50 down deals. And so, I mean, it's exactly actually what we were trying to do at Landmark when I was talking to the federal government about it. So I would say I would divide the world up very simply in that way into two categories. One is delegation, or real delegation, real risk, what I would consider capitation or 50 up, 50 down, and we need to enable that and assume, given our scale, again, you have a market of larger, more sophisticated folks that can do that. That's in that 30 to 50% range, because that's what it is in MA, and those people will open their doors when they can if the construct is right. Then you have 70% to 50% right of folks that not only can't they take delegation or real risk, I would argue they shouldn't take delegation or real risk. If you're a single physician, that's not appropriate. I view kind of risk as dealing jewelry in the diamond district, right? If you don't know what you're doing, you're going to get fleeced. And you know, that happened back in the 80s and 90s, where you'd see kind of groups in California when it was first coming up, really jumping into this without, and so I think it requires sophistication. Now, that said, you do not need to pay those folks on fee-for-service. Fee-for-service is what is driving a lot of this. And so let me give you an example. You think about primary care, you can create very simple outcomes metrics. They don't have to be that complicated. You can look at paying somebody a very simple fee, eliminate all this coding for revenue cycle, have some downside that is associated with risk-adjusted admissions, and have some real upside associated with risk-adjusted admissions. Not small money. And the good thing about PCPs is they're not paid that much as it is. They control a lot more cost. And so if you start saying, listen, instead of $200,000 a year, if you are keeping people out of the hospital and taking care of them, you're going to make $300,000 a year. That's real money. And that will, it will change around, again, what I was saying earlier, kind of everything is driven toward patients. And I was speaking recently and somebody said to me, well, you know, I understand you're saying payment models, but we don't have enough geriatricians and people don't have enough time to focus on these people and this, and so they should be paid, you know, $20 for each 15-minute phone. And it all roots back to payment. The reason we don't have enough people focused on complex chronic patients is because it doesn't pay well, just to be clear, right? It's because today's environment, if you're a PCP, for the most part, if you're not employed, you have to churn and burn and spend 15 minutes with the patient that's been teed up. And when a complex chronic patient comes in, you think, oh shit, now I have to spend an hour with this patient that may not even show up, and I have no real ability to take care of them. And I do believe the vast majority of physicians go to medical school because they want to take care of people. And so the key is not paying somebody for a 15-minute phone call. It's to say, look, if you're going to make a lot more by taking care of patients and keeping them out of the hospital, you won't have the voicemail that says call 911. You know, you'll respond on the weekend when somebody emails you and is sick. You will do some of those things that today you really can't do. It's really hard to run a practice and do that. So those are the kind of, so I would think, Molly, in terms of outcomes, exactly what Mandy was saying as she's thinking about things, which is depending on the level of delegation you can take. If you're taking full accountability for a patient base, we've got to let you have room to run. We've got to look at waivers that say, listen, you can really invest in things that others can't because you're really taking accountability here. If it's outcomes-based, there's a different approach, maybe a little bit less on the waiver side, but let's stop paying people based on an activity because that's where I think the root of our issues is.
Does that make sense to you too?
Some. Some. But what I do think is that there is a huge amount of data infrastructure that I think it will take to allow physicians to have that right ability to have the information they need to do the right thing. In addition to the payment incentive, I definitely agree on the payment. You get what you pay for. The reason we get a lot of hospital admissions is because that's lucrative. And it's not malice, like it's not doctors being malicious or not doing the right thing. They're working within the system that we've created. And so you have to move the payment levers. And that's why I think also that this is the right time to think about the healthy opportunities. As you're thinking about outcome-based, I think this is the time that you can make that stick. We're not the first two people who've ever thought about, hey, food's important and having access, right? But you have to pair that evidence with the right payment levers. But I do think, as I'm thinking about our own North Carolina implementation and what is holding back our provider community from feeling like it can take on more risk is some amount of data infrastructure to really know who is theirs. What is their downside, and how did that, and how do they mitigate? And I will say, as a physician, we're all risk averse people, and I shouldn't say all, but we are majority risk averse people, right? We do things to make sure that the worst doesn't happen, right? That is how we enter the world. If I thought about that patient I talked to you about, like I was worried about cancer, right? And she had food insecurity, right? But I was worried about the worst thing, and you just have to know that it's a psyche. And so if that is the issue, I think data and infrastructure, they are scientists, and I think really do want to see their data and their patients, and do respond really well when you say you're an outlier. You actually order way more head CTs than all of your doctors around you. They go, really? Mm-hmm. Well, first the data's wrong, and let me dig into that. And then they were like, oh, the data's right, and like, I'm going to change my practice. Mm-hmm. So I just would add to that a caveat of thinking about both at the state and the federal level, how do we support an infrastructure of that good data exchange where people rely on it, can do the risk adjustment needed to get mm-hmm. that all right. So, but otherwise, in terms of payment incentives, I totally agree.
You just began to touch on it there at the end, but one of the things that I always worry about when building these, risk sharing, reward sharing models is sort of that risk adjusted payment and the attribution model. What patients are attributed to you, because if we don't get the data right to be able to do that, the care systems will begin to get ahead of our payment systems and be able to select the populations that they're going to be able to achieve the savings that they're looking for on, and we will wind up underserving the people with disparate outcomes yet again, and our systems will fail. So trying to keep data ahead of these systems and be able to appropriately risk adjust and build the attribution models to allow the systems to understand the risk that they're taking on better are two of the key data pieces that I try to watch. How have you worked to address those?
Yeah, I think that, I'll give you an example. And again, it really depends if you're talking about, more delegation, full delegation, or whether you're talking about outcomes-based orientation. But a good example is we have our CPC Plus, Comprehensive Primary Care Plus initiative. We have 2 tracks now, track 1 and track 2. We're looking at a 3rd track that's much more outcomes-oriented. And there we have kind of a web-based tool that will show kind of them from a claims perspective, where they are, where outliers are, what it looks like from a risk-adjusted payment perspective. What I will say is, and it does some fairly simple kind of, here are your top cost cases. The problem with that approach is why we're orienting toward looking at artificial intelligence is your high cost cases generally, there's regression of the mean. And so looking at that as a fairly basic thing to say, these are my really high cost people, because not everybody comes back and is high cost. There's a fairly decent regression. At the end of the day, I would say the biggest issue, in my opinion, I think data is important, attribution is important. What I will say is it's very hard to operate in a system where you have a foot in both camps. And I believe that is the biggest issue. And what I mean by that is it's like kind of a blockbuster Netflix issue. You have folks that are either not fully committing, they're still on fee-for-service, maybe they have some upside, they've got multiple different models, they're being paid this way by commercial, this way by Medicaid, et cetera. So I think our job at CMS is, what do we have mostly right now? Scale. We have a lot of scale. And so when you look at the administrator and her push and looking at rules around ACOs, people say, why are you doing that? ACOs are in there. Why are you looking at eliminating upside only? There's some savings. What's the negative? And the negative is people don't commit. And so I think the key here, this is the most important thing, because ultimately I'll tell you statistically, like when we introduce CPC Plus, somebody will have 2,500 patients attributed, and they'll come to us and they'll say, these 5 patients, this or that, or that. I'll tell you, it doesn't statistically make that much of a difference, especially if you're working in quartiles. The key is having a volume that is really paid that way and committing 100%, or not, for that matter. I will tell you, value to me is not risk. It's not capitation. It's not, value is lower cost at higher quality. And so I'm actually quite fine with somebody saying, you know what, I'm not going to be a Kaiser. We're not going to taking delegation. But as long as they have a foot in both camps, kind of quasi taking delegation, that's not good. So we're trying to force a choice. So if anything, I would say that scale and that commitment is going to be very important to driving improvement.
And if I could add, I think that the payer alignment is really important here. And I think that's why in North Carolina, I am very hopeful on our success, because this isn't just Medicaid doing, right, Patrick Conway being at Blue Cross Blue Shield North Carolina, and this is the one time I'll say insurance consolidation is helping me here, because he owns 80% of the market in North Carolina, but you have what we're trying to do in Medicaid, his commercial business, as well as where Medicare is headed. We have a lot of Medicare Advantage penetration in North Carolina, and so there is a lot of alignment. And so I think that's right, that there is a tipping point where a practice and a health system says, okay, I get it, I know where it's going, and we're in. And I'll say this has not been the case in North Carolina. Very few entities are taking any sort of downside risk at all in North Carolina, but they see where I'm headed, where Patrick's headed, where Medicare's headed, and they're like, all right, time to get serious, time to, okay, what does this really look like? Let me get into the numbers. And the other thing I would say on this is that we have found helpful is that there are a number of vendors that are now, they've called themselves like the marriage counselors of downside risk, which I think is helpful. There's some distrust between payers and providers. Don't know if you knew that. Some distrust there, and sometimes a neutral third party that is not the government, that is not a payer, but that can help be a neutral arbiter between, okay, how are we going to set the price here? How are we going to set the parameters of what this risk contract looks like? I think has been helpful in North Carolina context, and we will continue to use those kinds of facilitators to help us on attribution and help us on those kinds of things. That has been helpful. But I think the moment in time and the alignment that we're all moving in a direction is also helpful for the provider community. They're like, okay, but stay there. Yeah. And I think to the earlier comment when it was like, when HHS under previous leadership was maybe moving away from that, they're like, okay, maybe I don't have to commit now, and now it's back, and so, okay. So I do think that commercial Medicare, Medicaid alignment is really helpful.
One other thing I'd add, and I think this is important too, I agree with what you said, Mandy, the one other thing I'd add is there's a bias, or there's a fallacy that is important for us collectively to kind of get rid of, which is that in order to take any kind of outcomes risk, you must have control over everything that happens with each patient. You know, I can't control. Yeah, that's right. You can't. Yeah, I can't. You know, the key is when you have enough of a sample, and that's where I mentioned risk-adjusted admissions as a simple metric for a single physician. The reason we chose that, we could choose risk-adjusted total cost of care, we could choose risk-adjusted nursing home visits, et cetera. Because risk-adjusted admissions is, one, it's very simple to understand, keep people out of the hospital. And two, it's statistically relevant given the sample size, meaning you can't stop everything. Nobody can. You're a doctor, not the person. Not everybody's going to listen to you. But the key is improving where it is, right? And so things are going to happen. If you're a good doctor and you're giving care, are you improving where it is? That doesn't mean you have to do it. And I'll say, like at Landmark, we had about a 55% engagement rate. That means 45 to 50% of the patients we never speak to. We couldn't get them on the phone. And we had full risk for that population. So people would say, Adam, how would you take full risk? Half of the population. But that's not important. Half of the population is going to revert to the mean. It's the 50% we do touch that drives an overall 30% cost decrease. And so that's the key there. You don't have to control everybody. You've got to overall make an impact, if that makes sense. And I think that's something people don't always understand.
I hope people picked up on the math of that, because it's very important in all of these. So unfortunately, we're out of time. I see other hands up, and I'm sorry we can't call on you, but it was a great, great panel. Thank you very much. Okay.
You're allowed.
I'm going to ask one question.
I could never control it.
Just to close, yeah. Good luck. I know what you guys do every day. I have a sense of what your days and your calendars are like. The people that you tend to see, that you tend to meet with, are people running hospitals, physicians, people who are controlling resources and assets. And one of the reasons why I think you're such an important panel is because we all feel so powerless in healthcare. We all feel like we can't affect the change. And you're two of the people in the Medicare program and the Medicaid program that actually have your hands on the steering wheel to the extent that many people do. So who you talk to, what input you take, and how you then prioritize become really interesting decisions when you're in a chair like you're in. we've got people in this room today that are patients, that are parents of patients, and that are patients themselves. Probably don't know half of the three-letter acronyms that were mentioned here, and probably shouldn't need to. So I guess my question for you is, we think about the next 5 years of moving healthcare forward, how do you meet the challenge, the very high challenge, to make sure you're taking patient impact and the voice of the patient and families into regard as you do your decision making? And what are the practical things that we can all do better? Because I found it important but very challenging to do when I was there as well.
Why don't I start, because I'm sitting in front of Natalie, who is an amazing mom and advocate in North Carolina, and quite the Twitter star, tweets at me sometimes, as she well should. But there's a couple very concrete ways. So first, as we've moved into our Medicaid managed care transition, one is that we brought the patient voice into the room. We literally invited a family to come to our all hands, all 800 of us, meeting as we were doing our work, because we need to hear from them first. So that was number one. But it's also grounding us back on that simple focus of buying health. Right? I think we can get caught in all the acronyms and the payment limit, but at the end of the day, we want our families to be healthy, to be safe, right? Your daughter is an amazing inspiration. And it comes back to, also, I will brag on my governor for a second. He has a very simple mission statement. He wants a North Carolina that's healthier, that's better educated, that has more money in their pocket, so they can live an abundant and purposeful life. Right? That's a huge charge, but it's what I think about every day we ground back to. And I think it's really important to make sure that we are building intentionally that patient voice into the work and ground back to health, and not health care, because we can kind of get all embroiled in that. But thank you to United States of Care for thinking about that in a very intentional way, and I think we can always continue to make improvements there.
A couple other thoughts. One is, I'll tell you something I do like about this job, which is, people come to us, obviously, and everybody, rightfully so, has a specific perspective, right? So they'll have the perspective of their industry, et cetera. Your job is to only focus on the American patient, right? And that is the lens that you see everything through. And so that's nice. And I will say, one positive about the current administration is that the current administration doesn't really care that much about other stakeholders. I don't feel like when we're making a decision and blah, blah association will be upset. Doesn't mean we don't listen to them in the context of patients, et cetera, but the feedback I get is, if it's the right thing to do for patients, do it. We don't care. And I always feel like, well, go have a conversation with the president, enjoy that. But it does let you be myopic about what is the best thing for people. And so I will say, it is always what we think about is this going to result in better quality, lower cost, and more choice and access for patients? That's 100% of what we think, and I like that about the job. The final thing I say, I didn't really focus on all the P's. The first P is patients as consumers, and just to reflect on that in the context of your question, the real focus there is, how do you empower patients to choose more of their health care and get more of the direct benefits? I think one of the issues of health care is, if you invest in your health care, it's not like Facebook where you sign up and you get an instant reaction. It's decades down. And so how sometimes patients make choices that are better cost, better quality, et cetera, and don't get any of the benefit of that. How do we make this more of a consumer-oriented approach where patients get some of the benefit? If they choose a high-quality, low-cost provider, and that's their choice, how can we let them share in some of the economics of that they wouldn't otherwise see? How do we make it feel like it's them making the decision? You have doctors that are counseling them, but they sit in the driver's seat and they get some of the benefit. How do we stream that to them? So that's another thing we're thinking about a lot to drive on the patient side.